All right, so the 4:35 session is my friend and someone I know very well. Immersive simulation that tackles public health crisis, and it's Devin Marble.
Thanks, Beth. Thank you. Hey guys, can you hear me okay up here? Awesome. I'm a loud talker, so I was trying to refuse the mic, but he gave it to me anyways. So today I'm hoping to give you guys some value. And I know a lot of people in this audience are probably more aware of what's going on with immersive solutions than other people, right? We're at AWE. The people here have built the augmented world solutions that are out there. So let's get started. Virtual reality is really, really great. I don't know if you guys have heard this, but 90% of students state improved retention. 80% of students would have looked for a VR course if it was in their listing. They would have wanted it. New hires are seeing 40% decrease in intern time, meaning they're not tied to a professional. They're doing solo patient care faster because they're more competent sooner. 65% of students would prefer labs in VR by themselves because they're more comfortable with a VR headset. 90% of students want VR learning at home where they are comfortable. VR levels the playing field. Talk over. The end. Thank you all for coming. You guys already know that stuff. That's not bringing you any value today. So I'm an emergency paramedic for 8 years. I'm also a VR educator. I do content creation and development for VR patients. And I'm going to try to poke the bear a little bit, guys. I'm going to try to tell you what to develop and what not to develop and why. And we're going to point to some major problems that need major solutions. And if you're financially motivated, pick problems that have millions and millions of people who are waiting for a solution. If you're motivated to help, pick a problem that has millions of people who need help. So that's what we're going to talk about right now. Who? The WHO has predicted a shortfall of 15 million healthcare workers worldwide by 2030. That's just in 7 years. The International Center of Nurse Migration, they project 13 million shortage of nurses alone. That's up from 6 million just before the pandemic. In a few years, it's doubled. This means that your immersive health solution, if you're building something, it needs to be accessible and scalable. We would love for everyone today, everywhere, all the time to have a VR headset on, right? Wasn't that what we saw in our opening keynote? It's just not a reality today. But you know what is a reality? We're coming up short on healthcare workers. You may end up in the hospital one day. You may have to call 911. You may have a loved one in the hospital right now. And we are falling short on healthcare workers, and they need a solution. And you guys can build the solution. The healthcare, they can't. They know how. We are subject matter expert. I know what to do. If your leg gets chopped off, I got you. But I don't know how to build that in virtual reality. And I can't train 15 million nurses or 2 million more nurses per year for the next 7 years without something scalable and accessible. Everyone's got a laptop when they join in college. That's why I recommend that your immersive solution be built on Unity. Unreal is amazing. It's beautiful. It's incredible. Make something, if you're going to tackle this problem, that is accessible on a laptop, a VR headset, maybe even an iOS or Android device. Let's talk about what the top hospital CEOs in the country are seeing. This is the game of golf over here on the right. The lower the number, the bigger the problem is. And the number one problem that hospital CEOs are seeing is personnel shortages. That's above financial challenges, that's above patient safety, government contracts, and the list goes on. This is just a snippet. It's ranked number one. So let's talk about an example and what you might build, right? So by the end of 2020, the nursing shortage rose to 1.1 million, and central line infections increased by 28%. So let's say you're like, wow, I'm going to create an immersive solution to help reduce central line infections and make an impact in public health. I'm going to create a solution. It's going to use haptics. Or no, it's going to use augmented reality. No. You know what? It's going to be hand tracking with 3D models. Great art. And it's going to, you grab the object and you're practicing inserting the central line. Then you got to clean the area, make sure all's good. That's how you prevent infections, right? This metric is not associated with the physicians, the advanced practice physicians who are inserting central lines. It's associated with the nursing staff, the care staff that are taking care of the patient after the central line is inserted. So you would be building the wrong solution. You would be building something that is cool, flashy, fun, but we don't need to train physicians how to do a central line like this or like this with no feedback. I want a physician who has touched a central line before and touched skin before if they're going to insert that into my body. I'm sure you do as well. So how do we tackle that solution? That problem. We need to create an immersive solution that helps train the competency decisions of the nurse or the healthcare staff that are taking care of the patient after they get their central line. What's the skin look like? Is it warm to the touch? Do you feel swelling? How about an engagement with the patient? How do you feel? Is it tender? I can make those competency decisions over and over and over in the comfort of my own living room in an immersive, iterative environment that can count for my CEUs and continuing education. So when I'm actually faced with the decision of why medication, why treatment, what dose of antibiotics should I give in advance to the infection so that it doesn't turn into a statistic, I can make those decisions in VR. And it's okay if the art is great, put the central line on the avatar and let it be. It's not about the 3D object. There's so much flash with being able to hold an invisible 3D object is not helping solve these problems in healthcare. In 2 years, our shortages in the US alone are going to be over 500,000 across multiple healthcare work sets, right, or professions. At the same time, people are getting older faster. There's just a lot of us. So people who are 65 and older are going to be aging out. So in 2019, there were 54 million of them. In 17 years, 2040, you think, oh, 17 years is a long time. There's going to be almost double. There's going to be 80 million of them. If we don't tackle that 15 million shortage problem, you got to tack that on top of it. Then you got to tack on top of it, what's the new central line infection problem going to be? My kids are 4 and 2. They're going to be entering the workforce during that time. What are they walking into? Are you guys going to want to go into the hospital during that time, or are we going to try to do something about this? Because we need to produce 2 million more healthcare workers per year now. If you're financially motivated, that's a large audience, guys. Hospitals need more people faster with equivalent competency. Why? Decision-making skills. This means your immersive solutions should scale both in cloud computing. It should be able to get pummeled by thousands of people at the same time. It should be cost-effective. You can't gouge people on this public health solution. And it should be medically accurate, all the way down from the CNA, people who wipe our butts when we're sick and in the hospital and I need to be rolled over. I was a PCT CNA at one time. I wiped a lot of butts. And now I'm a dad. I wipe a lot of butts. It's just a lot of butt wiping in life. This is no small bar, guys. Right, we want the CNAs, we want to cater to them, but we need to cater to the physicians, the NPs, the PAs as well. Let's talk about emotional exhaustion. We know that healthcare workers are exhausted. It's up 27%, their EE quotient, their percent of emotional exhaustion. Now, you guys you're developers, you're engineers, you're building the augmented world. You're not a therapist. But what you create should not contribute to the emotional exhaustion quotient. Now, as a healthcare worker, I want to talk a little bit about what is available to me when I worked in the hospital. I don't do patient care anymore, but I miss it. So when I had a patient who was, I'll never forget, it was a really hard patient. It was a loss. Mine is a 3-year-old drowning. It was the first one of the summer. That was like 6 years ago. And I couldn't save her. None of us could. That messed me up. But guess what? There were 50 more patients in the lobby. I know what field I entered. I wanted to get back out there. So what's available to me to help with my emotional exhaustion today? You might think, if I'm going to build a solution for this, I'm going to do a telemedicine, virtual remote, something for psychological healthcare. See, I disagree with that. I think it's a good solution. I'm not saying don't talk to a therapist, don't do mental health, don't build for mental health. That's all great. Telemedicine, upward from COVID, has been phenomenal. But if you're going to build something that's truly immersive, meet the healthcare worker where they are. We know why we got into this field. We want to make a difference. Give me the chance to try again. You can build me something or allow me to build myself something where I can try on that patient again and iterate and go, okay, I did do everything I could. And it is a no-win situation. And that's important for me to understand because now I can teach that downstream and train my department. Because what's the alternative? The alternative is I go to my boss or my nurse manager in the emergency department. I say, that patient really messed me up. I need a minute. She gives me a break, talk to HR. I speak to them. And they say, okay, you're going to do a critical stress debrief and meet with a therapist. And so I meet with that therapist and they go, wow, you're messed up in the head now. You need a day off. And what do? I don't take that day off because if I take that day off, then my whole team doesn't have me. And I'm the best damn medic in that emergency department. And they're not taking the day off. And if they did, you guys would all not have healthcare workers in the emergency department or in the hospital or wherever it is. That's not scalable. But what did I need? I needed to try again. I needed to get my catharsis out of doing what I wanted to do, which is trying to heal. So you can build a solution that allows the person to educate downstream. And you can't do this unless you build it with an authoring tool. If you have to give the end user, I guess you don't have to, but think of the power of giving the end user the ability to make changes to the patient. Because you might build a solution and it's all in one package silo, it's a game, and that's the patient, that's the game. But once I figure out how to treat that patient, the game is no longer useful for me. I need to change it. Because people will change every day. And that halo, that high acuity, low occurrence patient is coming back in. And maybe this time they're going to be 4 years old. I know they're coming back. So I need to be able to make changes on my end of the tool set. So I'm the subject matter expert. Don't pretend to know more than the doctor or the nurse at their subject matter expertise. Provide them with the tool to be a better, bigger, faster, stronger doctor, nurse, medic. So the American Hospital Association produced this article of 5 ways to ease staffing shortages now and into the future. And I just did a few little highlights here. Just take a step back and look at this. Look at the words: customize, advanced practice, millennial Gen Z destination, be cool, be fun, help reduce my emotional exhaustion by making my continued education fun. I don't like being death by PowerPoint. I know I have to recert on my EKGs. I know I have to recert on my PALS, my ACLS, but it needs to not add to my hours I already have to do in recertification. Integrate, create your own solutions. There's the authoring aspect again. Give them the power to build their own tools. And what you see here, this image, it's from the platform VR Patients. And that is the world's first virtual reality smart pump. If you don't know what a smart pump is, it's a little pump in real life, and it's got limits in it. It has saved countless lives when it was invented. So a nurse puts a smart pump on, hangs the medications, and it will notify them if they're trying to do too much infusion or overdose or whatever, because the med library is in it. So they just select the med, cross-check, hang, and the pump is smart. Now they can train in virtual reality. That's a good solution. Social determinants of health. That's what SDOH means. You guys are so lucky you're in an industry where the whole point is to immerse people in a place that feels like not where you're standing. So you have the opportunity to make a nurse know what it feels like and looks like to be in the living room of the patient who arrived in the hospital. And you might think to yourself, that's EMS. Why do they need to know that? Okay, so I pulled this from excerpts of the Future of Nursing, Charting a Path to Achieve Health Equity. It's a huge study. It's more like a book, really. And just look at some of these highlights. Education needs to provide nursing students with substantive, diverse, sustained, community-based experiences. So SDOH is all of the things in your social life that contribute to the determination of your health. Your environment, what you eat, where you live, where you work, what's your financial status, what's your socioeconomic status, what are your friends like, what kind of people do you hang out with, what neighborhood do you live in? All of it is your social determinants of health. That actually impacts you in the hospital, and nurses are being trained to think about those things. But they have to imagine it. and just do it through an interview. But if you build an immersive solution that allows somebody to select a different environment and see the patient in the moment and then bring him into the hospital and definitive care and be treated, you're including social determinants of health into their immersive scalable education. This means your immersive health solution at a minimum must reflect the diversity in the avatars and the environments. We are all different shades and colors, shapes, and sizes. I live in southern Arizona in Tucson. It's very hot, it's very dry climate. We have a lot of heat exhaustion. I need that. But we also have a large Hispanic community. I'm very close to the border. That's actually a large community who need, they have sugar problems. I can't think of the word right now, but they need their finger pricked to their sugar because they have diabetes. That's the word. Diabetes, I apologize. So I need to be able to have a reflective, diverse clinical set from my location. So I don't know everything, but apparently you know who does is GPT-4. So I just straight up asked GPT-4 the same prompt, the same question that I had in the first 3 slides, which is, hey, chat, the problem, the wave is here, it's coming. What do you think is the solution? But what I really wanted to know is, what would make the most immediate positive impact? And so it said a solution that would likely make the most immediate positive impact would be a significant global investment in healthcare education training programs. Number 1 thing we could start tomorrow. Education, what's number 2? It's technology. It's you guys. It's building immersive solutions because you know what these hospitals, organizations, ambulance companies, colleges can't do? They can't infinitely triple the number of admissions button seat chairs. But through distributive remote education, they can. But they need the solution. So what can an immersive solution do? You guys have the power of analytics. So let me tell you a little bit about what auditing looks like today. So I'm an organization, I'm accredited, maybe I'm training ambulance providers or I'm training hospitals, frontline workers, it doesn't matter, in healthcare. I have to be accredited. That means that an auditor one day is going to come to me randomly and say, hey, you gave Susie Q a certificate for an hour of continued education, or you gave them a license on January of 2021, so I need you to prove that. Show me what you did. And today, they open up a filing cabinet, they sift through, go to S, pull out a piece of paper that was signed by someone who no longer works here, and it says 0.5 hours and what they did, and there's a signature. That's the proof. That's what we have today. But in an immersive solution, now you can empower the educator to go, oh yeah, sure, I've trained thousands of people. What's her name? S-U-Z, boom, there she is, export. Do you want that in a CVS or a PDF file? CSV file? PDF, great, here's your PDF file. Also, we still have the digital patient. Would you like to try them? You can see every single decision they've made along the way. You can see all of their critical success metrics, where they failed, where they won, how many times they tried to prove they got that hour. And you can prove they actually spent the amount of time in that. That is huge power. It's a whole new world for auditing that you could help provide solutions for. So let's review. I'm not saying you need to do all of these things, but if you can hit 1 or 2 of them, you guys are making a real impact. Make sure that your immersive solution is scalable. That means if you're creating something that ties the proctor, the educator, to the student, one-on-one in an immersive simulation, you're limited. You cannot scale. That single educator cannot train 2 million more people a year if they have to stand in front of the student every single time. They need to be able to be asynchronous in some form. Try to be medically advanced. I'm not saying you need to do central lines, but be inclusive of the critical care nurse, the RN, the BSN, the CNA, the PCT. Don't just do first aid. That's not the problem. The problem are central line infections. Make work fun. That should be the easy part. You can provide something that's immersive and engaging, that's super fun, and make it accessible. That's why, again, I like Unity. Okay, so I'm going to make someone nervous. I don't think she's here right now, but Sonia Haskins is the program director. That's the end of the presentation. Thank you, guys. Sonia Haskins is the program director here. She's the one who set all this up for all of us here, okay? That's her. And she was a guest on our podcast, the Immersive Medical Podcast, and we just launched it today. There's no money involved here. Immersive Medical is a YouTube channel I run. It's free educational resource for public health, for educators. And she talks about what she thinks is the solution. And she talks about how virtual reality saved her life. So if you haven't met Sonia, meet her virtually and check out the pod, because she really exposed her soft underbelly for everyone to learn from. And it's really, really cool. All right, so next, I've got about 4 minutes left, and I have a video that I'd like to show you guys that's 3 minutes long. So before I go to the video, does anyone have any questions? Great. I'm going to show you guys a video, and just a fair warning, you're going to see some injured patient, but it's a digital avatar. No one's actually hurt. You're not going to see real blood, okay? But if even seeing it in a 3D avatar makes you sick, maybe, I don't know, close your eyes. I called an emergency paramedic and I asked him to tell me a story, a true story of a patient that stuck with him that he never forgot, and he didn't win on it. And while he was telling me the story, I built that patient in VR.
So I was once asked by my medical director what was one of the worst runs that sticks with me, and that I could have possibly done things differently if I would have had the training or had seen this type of run before. And I can never forget about he's probably late teens, early 20s, male patient that decided to catch himself on fire after dousing himself with kerosene. Long story short, he was very successful at doing such a thing. And by the time we got to him, the only thing that I noticed that wasn't burnt was where his shoes were on his body. Because when we took his shoes off, that was the only thing that looked like normal skin. Everything else was 3rd degree, 2nd degree with blisters. Just bad. Fingers looked like they were coming off like a glove. Still conscious. Multiple minutes after we got to him, he could only state that everything burnt and that it hurts, it burns, it burns. Very agitated. Airway was intact, but for how long? So as you sit and think about a run like that, I just kind of pose the question to you, what would you do? What would be your most important thing to accomplish in a short period of time to, one, help this patient, if he's even helpable, and to be the best you can be on that day for him? The questions of this kind of run just absolutely become mounting of what you can do for him, what's in your protocol, what's in your back pocket of tricks. How do you train for patients like this? The high-risk, low-frequency patients. It's daunting. That has been almost 20 years, and I still think about that. And what would you do differently to teach how to deal with that kind of patient to give them the best outcome? There was no training that I had for that. That day became the training. It's 2022. We should be able to improve our patient outcomes by training for anything. If I could build that patient in virtual reality and practice for the next time, I would in a heartbeat.
I hope I provided some value. That was just an example of one platform that is taking a stab at these problems. And that's all I got. Thanks, guys.
Thank you.